Good afternoon and welcome to the second installment of the Nurse Staffing Task Force Project Echo series. Session 2 is titled Transforming Cost into Value, Recognizing Nurses' Unique Contribution, and will be presented by Dr. Leslie Kelly and Dr. Vicki Good. Throughout the series, we will hear from members of the Nurse Staffing Task Force as they share recommendations and actions to tackle the nurse staffing crisis. I will be your host for the series. My name is Nicole Anselm, and I am a Senior Policy Advisor within nursing programs at the American Nurses Association. This is a 5-part series featuring content developed and presented by members of the task force. Our goal is to engage nurses in discussions around actionable steps towards tackling the nurse staffing crisis. You will earn 1.5 CNE credits for today's session. In the first part of the session, the imperative is introduced and information and context on how it relates to nurse staffing are provided. This part of the session will be recorded and made available for on-demand viewing at nursingworld.org. After the presentation, we will engage in discussions focused on actions nurses and nurse leaders can take towards implementing the imperative. We encourage you to participate in these peer discussions. To briefly review what we learned last week, the think tank recommendations were published in April 2022. The task force recommendations were published a year later in May 2023. The think tank recommendations focus on organizational changes that affect nursing practice. This includes recommendations on work schedule flexibility, the stress-injury continuum, and total compensation for nurses. The task force recommendations are focused more on policy impacting the nursing profession. These recommendations center around staffing standards, regulatory efficiency, and the value of nursing. However, what the two documents have in common is they both address recommendations concerning the healthy work environment, innovative care delivery models, and diversity, equity, and inclusion. Last week, Dr. Linda Cassidy and Dr. Sarah Delgado discussed how reforming the workplace environment is crucial in tackling the nurse staffing crisis. Today, Dr. Good and Dr. Kelly will look at ways to transform the cost of nursing into the value of nursing. This aligns with the next imperative of the Nurse Staffing Task Force: value the unique contribution of nurses. And now to introduce our speakers for today. Dr. Vicki Good is a nurse leader responsible for the alignment of nursing strategy for university partnerships, student pipeline, government relations, boards of nursing, and professional organizations across a large hospital system. She is also the past president of the AACN Board of Directors. Dr. Good advocates locally and nationally to ensure implementation of current and future standards of practice and care. Dr. Good served as a member of the Nurse Staffing Task Force and think tank to design strategies to address the staffing complexities we face as nurses today. Dr. Leslie Kelly is a health services researcher with a background in acute patient care, academia, and health system administration. Her research focus includes staffing, the health of the work environment, and improving nurse and patient outcomes, particularly those associated with clinician well-being. She serves as the scholar in residence for the Nurse Staffing Task Force. And now I will turn it over to our first presenter, Dr. Vicki Good.
Thank you, Nicole. We will, getting technology to work is sometimes a challenge. The session objectives today are we're going to look at 3 different aspects. One, how to define and measure the value of nursing care. Secondly, look at the unique identifier, nurse identifier, and the potential role it has to quantify the value of nursing care. Can everybody double check and make sure they're muted? I'm getting some background noise. And then lastly, to learn what roles nurses can take to advocate for compensation that aligns with the unique value of nursing. The third objective is really coming more from the think tank, and I'll explain that why in a little bit. So first, we're going to talk about what is the value of nursing. The recommendation from the task force was to advocate for the development and the utilization of approaches that quantify the impact of nursing on organizational performance and outcomes. What we're going to do is share with you some insights and some lessons learned or pearls of wisdom that you might be able to implement in your practice. But some of these may not work for you, and we understand that, but hopefully we can share and then do some further sharing when we break out into our group discussions. We all know that nursing is seen as a cost, and it is the largest cost to a healthcare organization. But hopefully we can demonstrate and show you how to flip that conversation to what is the value that that nursing cost brings. And so how do you display that and define that? Nursing's the glue of the healthcare team, and we're the one at the front line preventing errors and adverse events. So we need to get credit for that as we move forward. I think most of the time, people really think of value as a dollar figure. How much does something cost? And we have to think of it a little bit different. And when I went to look for the definition, I found these two definitions that I really thought fit nursing: a relative worth, utility, or importance, and something intrinsically valuable or desirable. And the intrinsic value that we bring in nursing just can't be understated. So the value of nursing, we have to really be able to demonstrate and to document the benefit provided by the nurse and the direct costs that a nurse avoids in delivering care and the cost savings that a nurse can generate. And these are conversations that have not been traditional conversations that nurses have had. We tend to refer to the art of nursing and the caring and compassion, but we don't think of the science piece and how to define that science and how that brings value to our patients and to the healthcare system. There are 3 metrics out right now in the hospital setting, and many of these, if you're in a clinic type setting, many of these type of measurements are also going on in your clinic setting that define or directly impact the revenue generation or the revenue stream for your hospital. And most of these we will show you are nursing generated or nursing influenced measures that we can really make a strong impact. If you look at data from the American Hospital Association or your state hospital association, you will find that the cost of these programs can add up into, between $10 and $30 million to your hospital bottom line. And certainly we can pay for a lot of nurses, with that kind of money. So I want to highlight these 3 different programs. The first program is actually an incentive program where hospitals can actually get paid additional money if they outperform the average performance, but they can also be penalized if they're not performing at least average, if not greater than average. So each one of the elements measured in this program are worth 25% of the overall score. The first one is outcomes, specifically patient outcomes. Most of those are hospital-acquired infections and other adverse events, safety, patient satisfaction, and efficiency. So they are looking at all 4 of these elements of care in order to determine whether or not a hospital either loses money or gains money in this particular program. And this is directly related to Medicare patients. The hospital readmission reduction program is strictly a penalty program. So if you don't perform at the designated level for the diagnosis, you can expect a penalty for your organization. These are looking at patients with a 30-day readmission rate. And the interesting thing is these 30-day readmission rates are all cause. So it doesn't matter why your patient was readmitted. If it has anything to do with their previous diagnosis or not, it still counts against the hospital. So as you think, the impact that nurses make on readmissions with discharge teaching, making sure that adequate resources are prepared, etc., you can see how nurses bring tremendous amount of value here. And the last program is a penalty program as well, and it's the hospital acquired conditions program. And in this one, this is looking at adverse events or adverse conditions that a hospital might develop while they're in the hospital. And so it's strictly related to hospital patient safety and hospital acquired conditions. The interesting thing is, if you noticed, some of these programs have overlap in what they're looking at. And so it can be almost double penalties to an organization at times, given the particular metric. So the impact on nursing on outcomes, I wanted to just display these two particular measurements for you. The value-based purchasing, you can see here the hospital-acquired infections, that it includes the mortality, person and community engagement, that is your HCAP surveys, and then efficiency, which is the spending per hospital patient with Medicare. So that's your cost equation. How much does it actually cost us to take care of that patient? Most of these metrics are directly impacted by nursing care. And then the other one is the hospital-acquired conditions. I've listed some of the hospital-acquired conditions that are included in this metric, but the other ones are your hospital-acquired infections. So I'm sure you're sitting there wondering, okay, well, how do I measure that impact? Well, Nicole is going to put into the chat for you the AHRQ, American Healthcare Quality and Research Organization, has developed a calculator that you can put in your number of infections that you have and a lot of different data points, and it will calculate for you how much every single infection is costing your organization. And you can use that data to show the value that nursing brings. So if you take an organization from having, 15 or 20 CLABSIs down to 2 CLABSIs, what is that exact dollar amount of impact moving forward? So that's, very, very important for patients and for the organization. I wanted to highlight 2 other ways that nurses can really contribute to value and have had tremendous success. One is the AACN Clinical Scene Investigator Academy. And if you go to aacn.org, you can see the Clinical Scene Investigator, as well as Nicole's dropping a link into this program. This program is ran by staff nurses, and during the academy, AACN teaches the staff nurses how to make changes and impacts to their work environment and to their patient care. The program to date has reached over 1.2 million patients, and over 500 direct care nurses have directly contributed to the program. They also teach return on investment skills as well to the nursing staff, so that they can actually document how much they're saving with these different programs that they're doing. There's information on the link on how you can participate or how you can sign up a team to participate in the CSI. The other opportunity that I wanted to highlight is Johnson & Johnson has always been a tremendous advocate for healthcare and for nurses in particular. And one thing they have started, they've done it this year will be their 8th year, is called the Nurse Hackathon. And it's nursehackforhealth.org. And this brings together a group of nurses over a weekend to reimagine their healthcare environment and to learn from people in innovation and change management on how to make changes in their environment. It's actually kicking off tomorrow, so it might be a little too late to participate this year. But keep an eye on the Johnson & Johnson website, because they are coming out with more and more resources for nurses to document their value, as well as to demonstrate value moving forward in this complicated healthcare system. So now I'm going to turn it over to Leslie to discuss the unique nurse identifier.
Thank you, Vicki, for getting us started and going over our objectives. So as Vicki mentioned, the task force and then in her work and others' works prior in the think tank, value was really an opportunity to talk about how nurses are really transforming staffing. And so we're not able to talk about everything related to that, but these three areas that we're discussing, starting with outcomes and then the unique nurse identifier and then talking about total compensation, were definitely some big themes that came out. So as the scholar in residence on the task force, this was a topic that came to me that said, can you look into this a little bit more? Because this is a theme that's coming up and we don't know a lot about it. And I got to come at it as a blank slate because I didn't know anything about it either. There's certainly experts out there, and I know some of them are on our call, but as a task force, we really dug into this topic and learned about it as well, and ended up making a recommendation in our imperatives document that you see here on the screen. So when we're talking about the unique nurse identifier, we're still in this space around value, and really our conversations were really everything that Vicki was talking about with this value-based care, the value-based models that we're moving towards, right? This is great that we're looking at rewarding outcomes instead of placing the emphasis on testing or prevention. So all this movement towards these models is good, but the problem was that we don't necessarily have a process or a way to look at how nurses are documented in this process, or how nurses contribute to this process, or other ways that nurses contribute to this process. So if you look at the way things are currently done, our current forms of documentation, our EHR, our IT systems, our billing systems, there's not a real easy metric for looking at the contribution of nurses. I know we always jump to nurses are built into the bed pay, right? So what we say, or what has been said in the literature, is that when there's a lack of data, there's invisibility. So this is where the conversation around the unique nurse identifier has come into play. Now, that being said, unique nurse identifiers already exist. And so that's when we went to look into the literature. We looked at what's out there, and then we brought back some of the slides that I'm going to show you now and talk about what's out there. So we started in our task force, and what I'm sharing with you now is, what is a unique nurse identifier? We call it a uni too, but that also sounded a little weird to me, so I tend to say unique nurse identifier. But it's a distinct numeric code that represents an individual. It's kind of funny, the more we got to talking about it, it's like we all already have a unique nurse identifier in some way or another. Like with our employers, usually if we're employed somewhere, we usually have an employer ID number, right? But a unique nurse identifier that we're talking about here would be something that's across the board, standardized for the nursing profession, for national, for one system of doing things. So we're looking at this being our one unique nurse code for everything. The potential for it is really what we're going to be talking about, not only here, but also hopefully in your breakout sessions as we move into this echo brainstorming and talking about and coming up with ideas. So the idea is that you could track, you could classify nursing services, billing, staffing, resources, kind of all these different things that you could think of, but not just within your own system or your own, setting or your own whatever way that you're using it, but across systems, and then eventually on to healthcare delivery or on to workforce, or however you may look at it. And then it could be done across employers, across states, because it's standardized. So when we talk about the uses or the potential for it, some of it's in the literature, some of it is still in that brainstorming, but the real goal here is the aggregation and that use of data, whether our potential thoughts or what they've been doing with mining specific data. And there is some already out there being done. So when you think about what, nursing does, again, what we do that can be tracked to the individual nurse and how they care for the patient, their assessments, their interventions, their specific outcomes on patients, and then that relationship to data and the influence that it makes on outcomes. Lots of thoughts around our nursing care time and our costs per patients. And then also thinking about supply and demand, especially related to staffing and our workforce and our movement of nurses across employers, across states. So with a standardized number like this, we could link it to other data sources and not just keep it within one system. So I mentioned that there's systems that already exist. Oops, and it looks like it jumped ahead. So I'm having my tech challenges now. So there are two main unique nurse identifiers that already exist out in the world. This short presentation is a little bit beyond our scope to take a deep dive into these, but I do want to mention both of them that are already out there, the two main ones that are already out there. The first being the National Council State Board of Nursing has a unique nurse identifier. We all already have that number if we have an NCLEX or we have a license number. So it's automatically generated for us when we become a registered nurse or an LPN or LVN at the time that we take our exam. NCSBN uses a third-party system called Nurses, and when we get our license or when we update our license, this information is updated. And so when this data has been made available to researchers, and again, it's for everyone, right? Everybody who is utilizing a license, so utilizing the National State Board of Nursing, has this ID. The other one that's out there, you've probably heard of and are familiar with, is the NPI, the National Provider Identifier. It is called the NPI for short. It's a 10-digit number. It is free. It's required for those that provide or prescribe. So RNs that do this, APRNs, physicians, dentists, chiropractors, people that are using CMS and Medicare services, the enumeration system, they have to enroll and receive an NPI number. Anybody who's using billing, they have to have this number. So it's not that you can't have it as an RN, you just have to enroll in it. So the thought is if everybody needed one, everybody would have to go out and get one. And there is a process of what they call bulk enumeration. So everybody could grab one all at once. It's not that we'd have to do this one-on-one, but currently all RNs do not have an NPI. So I'll just kind of wrap up with talking about some thoughts that have been out there around this conversation of unique nurse identifiers. And then I'd love for you to carry into your discussion groups what you think about unique nurse identifiers and how they might help or hinder our staffing workforce discussions, and how we could use this piece of information as one solution to helping our staffing, improving our staffing in the future. So obviously right now, the majority of nurses are not reimbursed for care. So as we take this data nugget, right, the potential to have a unique nurse identifier or utilize these unique nurse identifiers that we have, how do we take this? How do we use it as something that could be useful for us? One thought is the burden's really on the health systems to create these required, trusted, universal frameworks that we really need to come together as a healthcare system, which may not be our strongest strength right now, but it's something that might need to happen. Some discussion around unintended consequences, right? Kind of like we talk about AI, right? Some people are very for it, some people are very against it. This could be kind of falling in that same boat. Some people are really very concerned about having this national ID number linked to me and what's going to happen. Are you tracking me? Are you following me? Are you penalizing me? So lots of discussion kind of happens in that space as well. And then again, our conversation around, we've got two systems driving here right now, and we need to likely move towards one system. And so what does that look like? And what is our future in that space? So that's our unique nurse identifier discussion. And I'll hand it back to Vicki to wrap us up talking about total compensation.
So for the third objective, what we wanted to do was really highlight some actionable things that you guys could take away from this session together. If you look at the third imperative from the task force, it's actually to collaborate with payers to explore healthcare system payment models that reflect the value of nursing. And that's a pretty big, daunting task ahead of us in nursing. And it's something that will have to be dealt with on the policy level. So what Leslie and I wanted to do was really leave you with some actionable things. So we pulled total compensation forward from the think tank to discuss here with value. If you think about the timing, the think tank was going on right at the tail end of the COVID crisis. And we were really facing a lot of issues with, high salaries from our travelers and other, other colleagues. And it was really starting to compress the nursing workforce. And so what we wanted to look at was how should an organization develop a formalized and customized organization-wide total compensation program that really is all comprehensive and addresses all the needs of our nurses moving forward. As you guys know, I mean, right now we have every single generation working in the workplace, and the compensation needs of every generation are different. So an operational definition of compensation is exactly this: all forms of payment received by an employee in the form of salary, wages, and benefits. What we are starting to see with Gen Z is they are very focused on their benefit package and what kind of benefits an organization is offering them. And they're not asking for traditional benefits like what you and I would have wanted, like in a 401k or healthcare paid for, that sort of thing. They're wanting other things. The ANA, through the American Nurses Foundation, did a 2022 workplace survey, COVID-19 series survey. I highly recommend that you pull that survey and look at it, because there are some incredibly valuable things in that survey. But one of the questions they asked is, are you satisfied with your compensation for the services you provide for your organization? And 63% of the nurses in this survey said no, they were not satisfied. The survey went on to ask additional questions, and they asked, what are the most important benefits to you? Every person was asked to select their top three. So the top benefits that people wanted most was healthcare, retirement, and professional development. And I don't know about you, but most of the organizations around me have cut their professional development budgets tremendously. And that is continuing to drive a lot of dissatisfaction among the nursing staff. But if you look down further, you also see other benefits, childcare, and financial counseling as some other benefits that people are asking for. And what we're also seeing is that a lot of people are wanting non-traditional benefits. Some of those benefits include childcare, as well as dependent care or elder care. And we've also seen organizations having to start to compensate for living arrangements, especially in some of our large metropolitan cities where nurses can no longer afford to live in order to get those nurses to come to their city to work. Okay, there it goes. There's a little bit of a delay in changing slides. The this survey came from the advisory board, and what they were really looking at in 2023 or 2021 is, what are salaries doing? RN wages are continuing to increase, but what we're finding is that RN salaries are not keeping up with the rate of inflation. And so that is leading to a lot of dissatisfaction for nursing staff. As I look at this information and see the growth, outpatient centers are growing at a much more rapid rate than general acute care hospitals. But the one concerning thing to me is, if you look down at the bottom, our skilled nursing facilities, their wages are only growing at 0.23%. And I don't know about what you're experiencing in your part of the country, but in the Midwest, we're having tremendous challenges in keeping our skilled nursing facilities open, which then impacts our hospitals and our hospital discharge process. So I think that's something that we've got to keep an eye on, as we move forward. It's not only the hospitals that are getting impacted, but it's also all of the other providers in other organizations. So what do we need to be doing in the future to address total compensation? The first thing is really conducting routine market analysis. And the thing that we've got to start looking at and working with our HR partners on is starting to look at other factors. Traditionally, market analysis only look at your direct competitors in your area, in your geographical zone, but we need to include inflation. We've got to consider what external agency are making, and then we've got to look at market changes as well. And so these are some new ideas that we have to really partner with to address. The other thing that we're starting to see is with rapid rise in salaries, we're seeing a lot of salary compression, especially with our nurses with a few more years of experience, we'll say, than some of our other counterparts. And so the salary compression is starting to impact, our nurses with this experience. And, what we're starting to see is they're retiring in order to avoid this compression or, due to their dissatisfaction of their salary. So that is leading to, again, this whole experience gap that we're having in our hospitals, where the average age of our nurse in the hospital has dropped tremendously, and the experience level has dropped tremendously. And then lastly, we've got to look at how do we, implement creative compensation. Some different ideas that we have seen across the country is, doing sliding scale incentives. So you don't offer the same incentive every day of the week. Holidays and weekends might have a higher incentive than, a normal Tuesday day shift, if you will. So lots of different ways. And I look forward to the discussion because I want to hear more ways that you guys have seen, compensation be done in unique and in creative ways. The other thing is we have to look at flexibility. If you look at every single survey that has been done, with nurses in the past 3 years, and there's been a tremendous number of surveys done, every single survey comes out loud and clear that nurses want flexibility. It's interesting to me that we're still married to the 12-hour shift. How are we going to move away from that? And what is it going to look like? And it's going to take some unique outside of the box thinking. But one thing that my organization's really been working on is how do we build layers of workforce? So we don't have just one group of workers. So traditional workers is our core workforce. So that's our core labor market. Those are your full-time nurses or part-time nurses that are with you, day in, day out. And the one thing with a layered workforce strategy is you can't forget your core nurses because they are really the backbone and the foundation of your staffing strategy. But then you have to add flex. We will never get away from, not having travelers or agency nurses to supplement our staff. We're always going to need, that layer of workforce in order to sustain our work environments. But a new program that is starting to come across the United States, and Trusted Health has been a very good partner in this area, is a gig platform. So if you go back in memory lane, gig used to be a term that related to bands and people. I'm going to go have a gig at this bar, or I'm going to go have a gig at this venue. Now nurses are signing up for what they call a gig position, where they name when they're willing and available to work. And so they can go in this week and say, I'm available and I'll work on this day. And next week, it may be a totally different day of the week. And the gig platform, what we are doing in our organization is your salary is based on the demand for that particular shift if you're a gig worker. So you go into the application and you can see that Friday night we're severely short. And so your gig incentive to work that night is going to be much higher than a shift for Thursday day shift. So it really brings that flexibility to the gig worker, but it also rewards where the demand is the highest in the setting. So actions that we need to take forward as nurse leaders and bedside nurses is, one, we've got to start to disseminate evidence of nursing as revenue supporting, not only as an expense or cost. We've got to look at how do we properly code our work? How do we influence value-based payments and quality measures? And I saw in the chat, I was looking, John dropped an article, which I have read, and it's a very good article on, other ways for nurses to measure their value. I think number two is we have to keep up on our compensation surveys, and we've got to keep up on our compensation approach. So our compensation approach has got to look at more than just hourly wage. It's got to look at unique, needs of our nursing staff. So whether or not that's housing or, childcare or elder care, just lots of different ways that hospitals can meet needs. A lot of hospitals now are offering concierge services so that nurses don't have to worry about things at home while they're working. We've also got to revisit and revise our metrics that are used in nursing. So we've got to quit referring to nursing as an expense allocation. We've got to record and reduce to allow for that revenue production. How do we stop doing the things that have gotten piled on the backs of nurses that hinder us from doing the things that we need to be doing to take care of our patients? And then lastly, we've got to look at staff safety and satisfaction, because as we move forward, things like productivity, nursing hours per patient day, midnight census, and skill mix are going to continue to be drivers to how nurses are compensated. But we've also got to measure that against staff satisfaction and safety, because if we're focused too much on those drivers and not on the other, we're going to continue to have a bottomless a hole in the bottom of our bucket is what I call it. As we pour nurses in, the nurses are just exiting quicker than we can stop them. So now we will move to the question and answer period. So we invite you to put your questions in the chat, and then one of our colleagues will be facilitating the discussion.
Thank you so much. Hello, everyone. Rashida Jones here. And I'll start by saying or letting both Dr. Good and Kelly know about all the thank yous that are coming in for this informative presentation. I'll start with a couple of questions that were asked earlier on in the presentation. One by Yolanda Keys. She asks, she wants to know about the risk and benefits for National Provider Identifier, NPI, for nurses.
I think hopefully we covered that in the presentation, but I think maybe is it mean signing up for an NPI, or if we were to move to a system of NPI? And so I don't know, maybe we can discuss it more in the discussion, but I would say there's, you know, as we covered, everyone is freely available to sign up for the NPI. It's the people currently that charge that are using it. So I don't know, Yolanda, if you want to expand on that a little bit more about what you mean by risks and benefits of obtaining a number, or if there was something more to that. But as you can see, there's two systems, and we don't have a universal one that we've adopted yet. But feel free to ask something more.
Thank you, Dr. Kelly. Yolanda Keys, would you like to come off of mute for a moment to clarify? Okay, we'll move on to our next question. Now, these questions were added to the chat when you all were discussing total compensation actions. The first is from Bridget Potter. Curious if those mean values for salary are factoring in the hours worked or incentives offered for extra shifts during COVID for hazard pay. Again, this is when the slide was up on total compensation actions to provide further context.
Right. My understanding is they used the base salary and not incentives, because we did see an increase in base salaries as well as all the incentives during COVID. But to be 100% sure, we'd have to go back to the authors of the study.
And Brenda also had a question again on this slide, which was, does the mean value reflect overtime?
I am not aware that it does. My understanding is, again, they were using the base salary so that they could look at consistency year over year, is my understanding, because I'm in an part of the country that nurse salaries are not real high. And those dollar amounts would, to me, look like their base salary. You know, based on what I know, I'm paying my nurses to work overtime. It wouldn't be near that salary.
Thank you. And we do have a few questions coming in here. So from Catherine Riemann, do we have any evidence on nursing worker status, such as flex or gig, and patient outcomes or quality of care?
I know that numerous organizations are starting to measure that, because if you think about it, some of this flex and gig staffing strategy is pretty new to the market. So I'm aware, I know our healthcare system is launching on a pretty big study related to this to look at the variability there. What we're seeing anecdotally is there is not an impact. In fact, there's a positive impact because it's bringing people to the bedside to take care of patients that we haven't had in the past. So I think it's one of those, trade-offs that you're having to make in order to meet that flexibility, but yet get workers to the bedside.
Thank you. Beth Ann Mendez asks, are there any defining elements within the professional development bucket? Any specific elements identified as the biggest needs?
I think overall, the one thing that we're hearing from people is that the inability for nurses to attend professional conferences. Most organizations have really eliminated their travel bucket. And, one of the beauties of COVID is it brought to light the fact that we can deliver educational content like this in a virtual setting and be flexible. But it also takes away that connection piece that we all desire to have with our colleagues. And so what I'm hearing from, my colleagues is that desire to be able to go to some of these conferences, to be able to re-engage with their network.
Thank you. We have a few more questions here before we transition. One is from Michael Alul. Since most direct care nurses are not reimbursed by insurance and included in bed cost, what do you suggest is a reasonable cost for a nurse that could be billed to the insurance or CMS?
Yes, I think that's outside of my scope, maybe a discussion for, people that are working in this space. And I know our expert on this is John, and he's in our session, but in the realm of what we're looking at for staffing, we're talking about a unique nurse identifier for something different. In our APRN group and staffing, that's again outside of what we were talking about with our task force, but I think there are certainly other experts that could do that. And I'm sure there's evidence on that too. I apologize, it's not in my realm.
Thank you, Dr. Clay. We have one more question here. Although questions are coming into the chat, please know we are going to do our best to get to them and answering them via the chat if we have not answered them here in our Q&A. One last question from Bo Vanis. For the nursing survey for compensation recommended, is there any information in regards to what questions we should be asking?
I think it's just a very simple question is, what is your biggest need from a compensation standpoint? So it's an open-ended question to really dissect and understand the needs of your staff. So over the year, one benefit that we've added is volunteer time off in order for people.
Dr. Good, I think you muted yourself.
I'm not sure how I did that. Sorry. I'm not sure where I muted myself at, but one thing that I was saying is it really needs to be that open-ended approach to ask staff, what do they want and what do they desire? I think, one thing that we just started doing over the last 2 years is paying 8 hours a year of volunteer time to every single person in our organization. One of our, missions is to serve people. And so that allows people, because what we found was people weren't willing to use their own personal paid time off to do that. So now we have that voluntary time off. So there's, unique items that bring joy and well-being back to your staff, and you have to look for what those are.
Thank you. Thank you, Dr. Good and Dr. Kelly, for this informative presentation. It's sparked some really great discussions in the chat. Thank you also to our audience for your great questions that you've added in the chat as well. Again, if we have not gotten to your question, we're going to do our best to answer in the chat. We'll now transition to our breakout session. Please hang tight. You will automatically be assigned to a room. Before we are assigned, I'm going to pass it back over to Dr. Good, who is going to review the discussion questions for today.
So as we move into our breakout groups, getting to that slide here, we have 4 fundamental questions we would like for you to explore. The first one is, and you will have these discussion questions in your group as well, but how do you see the uni being used in your organization, research, or practice? The second one is, what types of compensation models or innovations are you seeing in practice? 3 is, list actionable steps nurse leaders and hospital executives can take to advance and implement these recommendations at the individual level, the institutional level, and the policy level. So I think the question, the number 3 really is, referring to the first 2, and how would you see these actually coming to practice?
One key takeaway from our group discussions. First, we'll have Dr. Good share her group's key takeaway.
All right, well, we spent most of the time really exploring the unique identifier because I think it really scratched some heads and made people start to think differently about, how we deliver care. But we talked about some of the unintended consequences, of course, that would potentially arise. But one unique perspective that we discussed was how that number could allow us to really dive in and understand the unique perspective of each nurse, based on the number of years of experience the nurse has, and looking at, what their abilities are to take care of patients, what their workload, how much of a workload can they handle, and some other different research potential opportunities was really where we focused on the unique nurse identifier. But lots of questions on, how that would really work. So hopefully John can drop in, the chat for everybody, some of the national work that's going on related to compensation, related to the unique identifier, because I think there's a lot of interest on that.
Thank you, Dr. Good. Next, we'll have Cheryl Peterson share her group's key takeaway.
Hello, everyone. We had a really great conversation in our group. We kind of went through all of the questions that were there, but really kind of landed on the importance of flexibility. There aren't a lot of nurses who at this point are being compensated from both beyond and across the board to some kind of merit pay, which can be a bit of a dissatisfier. But we also, in the end, had a discussion about it's not always about pay, but about the work environment in which nurses are providing care and wanting to see management and leadership in the space. We also did have a conversation about the UNI and the, the uses that it could be, where it could be useful. Thank you very much.
Thank you, Cheryl. Next, we will have Dr. Kelly's group.
All right, thank you. So a little quiet in my group today, a few of us discussing, but I think what I saw from my group is there's a lot of wisdom in these nurse leaders, and they definitely have some caution around the uni and why do we need it? What's the association with outcomes? It's funny that your group was talking uni, Vicki, my group was talking models and compensation and gig. So we talked a lot about really the need for flexibility, just like you said, and some best practice examples for layering and being nimble, and really just, again, the wisdom that's out there with our health systems and what's already taking place and how we utilize our nurses and how we emphasize these best practices in layering the approaches for staffing. That's what we're sharing.
Thank you, Dr. Kelly. Next we have Dr. Shepard's group.
Thanks, Rashida. So it's really interesting. We had a really good discussion as well. We did talk a little bit about the uni, about some of the challenges and some privacy issues related to that. So to kind of reiterate some of what the other groups talked about also, we did talk a little bit about some compensation models. But the conversation really started taking off more when we're talking about the implementation and what those action steps are. And what was really interesting was the link between ensuring that nurses are engaged in this discussion to help with that decision making, because that could drive where that implementation starts. So whether it's at the individual level, institution level, and policy level, federal or state, that the group felt that, and those who are commenting felt that that would be driven based on what decision was made and what model was adopted. So which I found really interesting. But the main points was that we have to stick together as a profession and come to that decision that way as individual nurses advocating for the profession. And then dependent on what that decision was, where the implementation begins. And then another part was ensuring that implementation does not take too long. Because we know that's a lot of times, especially at the institution level, sometimes things don't get implemented quickly, and then it falls away, and then people get bored, and then it just goes nowhere. So really creating the structure and the guardrails around protecting that implementation timeline, so that way it still keeps the momentum going as we start to build this up for us. So yeah, really interesting.
Great, thank you. Next, we have Dr. Boston Leary's group.
Yes, hello everyone. My group was similar to the experience that Leslie shared. People still want to learn more about this, what it means, the implications, how, and then maybe move towards understanding how it could be implemented. But I think there was across the theme there was agreement about how people felt when they first heard that nursing services are wrapped up in room and board, and everyone felt angry. But how do you move from that anger to setting up the value proposition for nurses to want to do this, and allaying their concerns about, this feeling like a big brother type of setup for them as well. But there was comments about how this could be an excellent idea from at least one person, and how nurses are anonymous when it comes to care, and we need to put an autograph on the care that we provide, and use an example of what tends to happen with scorecarding in surgery with surgeons. So we talked about compensation opportunities as well in packages. There's a comment about how in most institutions you have physicians parking close to the building, and nurses having to trudge far away, particularly in inclement weather, and how that sets up the inequities. But and also an idea about money per a certain stipend a week for wellness needs, which shows caring and compassion. But overall, in terms of compensation packages, they're usually not negotiable. It's under one of those take it or leave it types of things outside of the salary, and that's something that probably needs to be changed as well, where there's not much flexibility with packages, benefits outside of salary.
Thank you. Next, I'll share the takeaway from my group. One of the participants, Grant Campbell, shared a fantastic compensation model that his organization had utilized, or rather implemented a couple years ago. It's essentially a clinical ladder type structure where nurses are compensated according to their skill level. So it's called paid for skills. So for each level, they identified a certain number of skills that nurses should be demonstrating, and these nurses were compensated according to how many skills in that level they demonstrate on a day-to-day basis. So what this did for the organization was it corrected the compression issue, and it compensated nurses appropriately according to their skill levels. And two, it allowed the organization to be competitive for in-state and out-of-state nurses because they were able to give and they were able to give an upfront compensation number to the nurses as they were being recruited. And lastly, we have Nicole Vernon's group.
We were the rogue facilitatorless group, but in listening, some of the key takeaways I got from our discussion, mostly on the uni part, were that some systems already are gathering parts of this data. So unifying that on hand hygiene, scanning medications, etc., could be of value, and several members thought it would be of value. However, there was definitely agreement that this needs to be very streamlined so that we can capture those many invisible tasks that are happening, but it can't add to the workload. And it was pretty unclear how this would translate to all systems. We were just getting into an interesting discussion of how mental health especially gets left behind on some of these like skill-based things. How do you track the interactions and what's happening there? And because that data is lacking, the pay is often lacking. We also moved into a discussion of internal travelers versus external travelers. That's what I got out of our discussion. Someone else may post in the chat if they got other things.
Thank you so much for sharing, and thank you for volunteering to share the discussion takeaway with us. As we wrap up today's session, there's just a few reminders I would like to share with everyone before we end for today. Don't forget to claim your CNE credits by completing the evaluation form, which will be placed in the chat. You will earn 1.5 CNE credits for today's session. And as a reminder, you can earn an additional 4.5 credits by attending our next 3 sessions. I would like to thank our presenters, Dr. Kelly and Dr. Good, once again for their presentation today. And you can join us next week on September 28th as task force members Dr. Kirsten Henry and Dr. Katie Boston-Leary discuss how innovations in care delivery models can address the nurse staffing crisis. Thank you everyone for joining today, and we hope that you enjoyed your time with us. And we look forward to having you join us again for our next 3 sessions of the series.